Dear Professor Minkov, dear Professor Mashan, dear colleagues, I first would like to thank the organizer of this conference for the invitation, for the ability to have a speech here. In this study, I represent Federal Research Center for Pediatric Hematology Oncology Immunology, named after Dmitry Rogachev, but not the main institution, but the branch named Ruskое Поле Rehabilitation Research Center, very far from here, about 70 kilometers, located in some good location. This resort area was captured by our main institution, Rogachev Center, 2 years ago. It was earlier the area, the luxury compartment for former leadership of communist dictatorship in the 70s. And during last 2 years, we redeveloped this area for the very good rehabilitation center for children who survived different pediatric cancer and hematological diseases. Here you can see the building and winter swimming pool, hot swimming pool, very good area around gardens and forest. Some of the tasks we have when we began our work to study patients were the studies of late effects. My main interest is Langerhans cell histiocytosis. I act last years as a national coordinator in the LCH4 study, which Professor Minkov named in his report. And in these facilities of our rehabilitation center, we performed a study of permanent consequences, late sequelae, late effects of LCH. Everybody who knows this disease knows that this disease has variable biological behavior, from life-threatening conditions in young children to self-healing lesions. And the most interesting feature of this disease is the ability to develop some very severe sequelae, maybe months, maybe years, maybe decades after the onset of the primary disease. These permanent consequences can be very different, from mild to very severe. The most common is endocrinologic and neurologic conditions, but there are also some orthopedic, some problems with the lungs, and so on. There are some typical compressive fracture of the vertebra, neurodegenerative lesions, which are very known to each of you. The main objective of our study was the evaluation of clinical features and severity of permanent consequences among survivors of pediatric onset LCH. We started our trial just 1st of January 2015. During this time, this year and a half, we admitted 59 patients with Langerhans cell histiocytosis. We admitted only 25 whom diagnosis of Langerhans cell histiocytosis was produced more than 5 years ago. Unfortunately, we have also some criteria. Age 18 years is the oldest children which is allowed to admit to our center because it is a pediatric center. So we can't follow the late effects which can occur in the adult age. Describing the cohort of our patients, I can say that the median age was 9 years. The males were prevalent. The time from the diagnosis was with a median 8.5 years. There were the same numbers of multi-system and single-system disease. 24 patients received chemotherapy. One of them received also radiotherapy, and one didn't receive any therapy, and his lesions disappeared without therapy. 8 patients survived also reactivation in some in their age. Here in the map, you can see the places from where these patients were transported to our rehabilitation center. In comparison to this, to the other studies performed anywhere in the world, where the doctors were able to work mainly with the reports from the different places where the survivors or the different diseases persist, where they live. We can work with a living being. We can invite patients from anywhere, from our different parts of our giant country, and perform an examination, physical examination, and to see ourselves what problems, what the severeness of the health condition the patients have. These patients were from different parts of the country. They belong to different social classes, different nationalities. There were Russians, Arabs, Udmurts, Dargins, Chechens, Bashkirs, and other different peoples of our great country. To estimate the severity of late effects, we used Langerhans cell histiocytosis morbidity score, which we found in the publication of Van Santen and Dury from Great Ormond Street Hospital in 2006. This publication helped us to understand what we should look for, what we should find among these late effects, among this study. So in this paper of Van Santen and Dury, we found the severity score. There were 4 points of severeness from 0 to 3 in different systems of the patient. And in her paper, were seen that the most patients were with physical features. There were about half of the survivors, and with endocrine disorders. But the most severe disorders, the purple one, are the disorders of the central nervous system, like ataxia, like psychological disorders, severe psychological disorders. In our study, we can say that we have slightly different results. Yes, about half of the patients had different psychological disorder from mild to severe. And also we have a great proportion of endocrine disorders. As was also in Van Santen and Dury paper, the most severe disorder was in the CNS and endocrine system. Our study looked like this layered pie in the picture. So when we admitted a patient, we worked as a single team of different doctors who had different levels of assessment. So there were specialist endocrinologists, neurologists, psychologists, hemato-oncologists, and we performed also a great number of different tests to estimate with late effects. At first it was a neurological assessment. We used in this assessment ICARS score of ataxia and ADSS score used normally for multiple sclerosis to understand the severeness of this disease. And after this neurological assessment, we used, after this routine assessment, we used also some instrumental approach like evoked potentials, MRI, and EEG. Our study showed that we found 3 cases of neurodegeneration. We proved it. One was proven before us and just came us with a proven diagnosis. And in 2 cases, we were the prover who found this patient, who told the patient and the doctors far away from Moscow how to treat them. It was very interesting because our study had also a very important social role. But it was also very important for us that only 1 case of neurodegeneration had a CNS risk lesions, so known CNS lesion, craniofacial bone involvement at onset. In the other 2 cases, there were just ordinary single system lesions at the onset, but both of them were treated with chemotherapy. In the last 22 cases, among last 22 cases where no neurodegenerative disease was diagnosed, about half, exactly 50%, had non-CNS risk location. Endocrinology assessment contained anthropometry and blood chemistry, blood hormones, and dextrodensitometry. We found severe panhypopituitarism only in one case with neurodegenerative disease. In 6 cases, we found diabetes insipidus. In 4 of them, it was diagnosed from the very beginning of the disease. But it was very interesting that in 5 cases, it was multi-system disorder. In 1 case, it was CNS risk lesion at onset, and 3 patients survived reactivation. In 2 cases, we found short stator, and 2 cases, we found hypothyroidism. Psychology assessment contained routine psychological consulting, but we can't find something interesting from these routine methods. Most interesting for us were non-verbal methods, PC-based, with a lot of data which we can find in this, from these methods. We measured 3 areas. At first was intelligence assessment. We used Raven-Scarlett progressive matrix for this. We used behavior problems assessment in different scales and cognitive functions using special contact eclipse machine. We used, for estimation of the intelligence, we used a very interesting non-verbal method based on these colored progressive matrices. So the patient should follow this picture, should complete this picture. And there are different tasks from mild to very difficult for children. And we found, after this assessment, that in 2 cases there were very severe intellectual disability. 1 case was neurodegeneration, but the other one didn't have any neurodegeneration. Mild developmental disability were found in 11 cases, and only 1 had neurodegeneration, but normal or above average intelligence score was in the other half of the patients, and 1 of them also had neurodegeneration, but no any problems with the intelligence, with the level of his intelligence. For the estimation of cognitive function, we used this CANTAP, Cambridge system. The patient decides different tasks on the PC screen, and we estimate a lot of different tests. Which give us different information about the accuracy of the making of this test, about the time which was spent to completing these tests. This study showed us that most of the patients which had cognitive disorders had problems with the switching difficulties and the memory disorders, disturbances of attention. All of this showed us that they have problems with the frontal cortex, but we didn't find any clinical correlation with the underlying disease in these cases.
Please come to conclusion.
Yes, and the conclusion is permanent consequences in survivors of LCH can be found very often, and we need sometimes special examination and treatment of these diseases. And at the end, I would like to thank all the collaborators, inspirators, all our teams which worked with us in this study. Thank you.
Thank you.